Thank you. My name is Aleassa from the Cleveland Clinic. I'm a fellow there. Um, Green button, I guess?
Yes.
Okay. So we'll be talking about the effect of revisional bariatric surgery on type 2 diabetes. I'd like to thank the panel for giving me the privilege of the podium and the audience for sticking around. I'll make it as short as possible. So I don't have any disclosures. So to set the stage and very briefly, going back to when we realized that obesity is in fact an issue, and then we discovered that bariatric surgery is the way to go for a large subset of patients to help them lose weight. So we started doing more bariatric surgery procedures. And as time passed, we started gathering more long-term follow-up data. And with that, we realized that there's a small subset of patients who present with issues with weight regain or a failure to reach their optimum weight loss, and in other patients, procedure-related complications. So as us being wise surgeons, we don't like doing surgery, so we tend to go for non-surgical interventions. That seems to work like a charm for some patients. Unfortunately, a smaller subset from that subgroup end up needing surgical revision, and then we go ahead and do that. Good fix for many things, and at the same time, we've seen that it produces further weight loss. There's always a but, though. What about its effect on diabetes? So our study we aim in this study to assess the effect of revisional bariatric surgery on type 2 diabetes by specifically the type of revision, so the index to whatever conversion was done. So to do that, we went ahead with a retrospective chart review, looking through our prospectively maintained database at the Cleveland Clinic. We went and checked charts spanning from 2008 to 2017. We included all patients who are 18 years and older with type 2 diabetes at time of revision. And we excluded all patients with missing data, such as missing A1C levels. So our chart review had some demographics. We looked at the index and revisional procedures. We also looked at the median follow-up of these patients. Some labs that we looked at were fasting blood glucose and A1Cs, as well as the patient's medication use being insulin, and also we looked at non-insulin medications. So we looked at 2 time points, time of revision that was our baseline, and then the last follow-up. Having all sorts of patients in our cohorts, we decided to divide them by index to the revisional procedure, and we end up with the following subgroups. So vertical banded gastroplasty to gastric bypass, bands to the respective revision, it being a sleeve gastrectomy, bypass, or duodenal switch, and then sleeve gastrectomy patients to bypass and a separate group for a duodenal switch conversions, and then revisions of the gastric bypass itself, it being either a pouch revision or anastomosis revision. So we had a total of 123 patients. We excluded 42 patients, unfortunately, due to missing data that left us with 81 patients to analyze. So the median age at time of revision was 57 years, with a female predominance of 73%. The median follow-up time was 22 months. I have a bunch of busy tables, but I'll guide you through them and walk you through them as well. So the most common revisional procedure we had in our cohort was revision of the bypass itself at 27%, and then VBGs to bypasses at 25%, followed by band to bypass at 17.3, and then sleeve to bypass, followed by band revisions. So length of follow-up was highest with the band to bypass at 43.5 months, followed by band to sleeve at 38 months, and then 35 for the sleeve to duodenal switch. I just want to point out something here as well. So the conversions to duodenal switch were very small in our cohorts, so the numbers might not be all that great for that. So moving ahead, looking at, well, with our results, so looking at the weight trend. So the highest median reduction was noted in the sleeve to duodenal switch. Mind you, we only had 3 patients in that group. It was at 43.5 kilograms reduction, median reduction, followed by band to sleeve at 31.4. And then we had the revisions of the gastric bypass itself at 29.4. They were all clinically significant. Sorry, statistically significant as well. BMI as well, we saw pretty much the same thing. The reduction across the board. Highest was with sleeve to switch at 19.8 points. And again, all of them were clinically statistically significant. Now to the punch. So the fasting blood glucose was also decreased across the board for most of them. So the highest was with VBGs to bypasses at 36.5 milligrams per deciliter, and then followed by revision of the bypass itself, followed by the band. So we saw the reduction in all of them with statistically significant reduction as well, except for the sleeve to bypass, but yet there was a decent 11-point reduction. A1C, also we saw reductions with conversions from the restrictive procedures to malabsorptive ones. The highest was with sleeve to duodenal switch, followed by the band to bypass, and then VBG to bypass. Again, statistically significant, except for the sleeve to bypass. Looking at the medication use, we've seen reduction across the board. All were statistically significant, except for the sleeve to bypass again. Insulin use. So patients who were on insulin eventually got off insulin if they were switched to duodenal switches. Band to sleeve was next at 50% reduction, or reduction, and then 44.4 with band to bypass, and so on. So I want to highlight this point. So with the bypass revisions, they went down at the 1 year point. So 2 patients were off insulin, and then all of them went back on it on the last follow-up. So to summarize, we did note in our cohort of patients further weight reduction and diabetes improvement after revisional surgery. That was mainly with conversions from restrictive to bypass procedures, corrective surgery for revision of pouch and stoma after bypass as well, and then reoperation across the board decreased the need for insulin use. Again, we had some limitations, as with retrospective studies. Our sample size was small. We had a bunch of missing data that led us to exclude some patients. So to conclude, revisional surgery in patients with persistent or relapsed diabetes after bariatric surgery can significantly improve glucose control, and further clinical studies are needed to define the mechanism behind that. Thank you, and I'll take any questions, if any.